Good morning and good afternoon, tribe. I'm so thankful that you have joined us today. We're going to talk to Galya about her experience in, am I saying your name right? I didn't even ask.
It's Galya.
Galya. Oh my goodness. Thank you so much. I apologize. Galya. We're talking to Galya today about her experience in the burn unit. She has been a graduate since 2019. She spent her senior preceptorship in the burn unit and fell in love. So she is excited to someday be a clinical instructor, and she has joined us today to answer your questions. So welcome. Can you introduce yourself?
Sure. Hi, my name is Galya. I am a new grad nurse. I did take the NCLEX in July of 2019, so it's been about a year. Shortly after I started working in a burn unit, which is where I really wanted to be after I had my senior preceptorship. I fell in love with the patient education. I fell in love with the being able to see the patients heal.
That's amazing. And as an icebreaker, I like to ask for you to share your funniest nursing story.
Okay, so I don't know if this is necessarily a nursing story in general, but I feel like it's funny, and it happened at work. So basically, I was walking down the hallway, and my name is hard to pronounce, and we had a patient that was just yelling, "Gail, Gail, Gail," and I thought he was on the phone. So obviously I didn't, stop to step in his room. I figured if he wanted something, he'd have the call light on.
Sure.
Right. So I'm just walking past, and I just keep hearing Gail, Gail, Gail. And, I'm like, oh, maybe his wife's name is Gail, whatever, not thinking anything of it.
Sure.
And then a few minutes later, the nurse walked in and said, what do you need? And he said, wow, that Gail girl is so rude. And the nurse is confused, like, who's Gail? We don't have a Gail on our floor.
That's so funny.
And they realized it was me. And now I respond to every name in the book, basically.
That's hilarious. And I'm sure your coworkers jokingly call you Gail.
What?
And I said, I'm sure your coworkers jokingly call you Gail.
All the time.
That's awesome. You've gained a new nickname.
Yes.
So before you did your preceptorship in the burn ICU, did you know you had a passion for burn nursing?
So before I did my preceptorship, I don't necessarily think I had a passion for burn nursing in general. I had a passion for nursing, definitely, but I didn't know what kind of nurse I wanted to be. So after one day of shadowing in a burn unit, I decided I would beg and plead, do everything I can to get my nursing preceptorship in there. And I was very annoying, very persistent, and my teacher got me, because we had the senior preceptorship were placed based on a ranking system.
Okay.
So we rank our top, picks. And obviously burn was my number one choice. And most people just, would let it go, wherever they were chosen, they would get. But I was completely on her every day, I'm going to be there, blah, blah, blah. And she eventually ended up telling me a day early that I was going to be in the burn center.
To shut you up?
What?
To shut you up?
Yeah, basically.
That's so funny. So did you do anything throughout nursing school medically related that would have prepared you for the burn unit specifically?
Well, I think just the preceptorship that I did. And I think that whole semester, I really focused a lot on burns and burn education, because really what I was seeing was a lack of resources and a lack of education involved. When burns were coming in, they don't really know what to do, what to put on burns, stuff like that. And I really wanted to, learn about it myself more and try to educate the community. We have Burn Week, which is in February. We have all these different opportunities to be able to educate people on burns.
Wow, that's really neat.
Yeah, I actually got to go to Utah to the National Student Nurses Association conference. and present my poster on burns.
That's incredible. You should share it someday in the Tri-Bar-In group if you can. You can take a picture of it, or if you have any other information you'd like to share, we'd love that. You can post it at the event too. That'd be so great. So we'll get into the questions that people submitted. We got quite a few people interested in you answering their questions, so we'll get at those. Ivan asked, is this a good place for a new grad to start? And if not, what type of nursing would you recommend prior to applying for the burn unit?
So obviously I started here as a new grad. I think it is extremely difficult, and it's, you're going to have to put in a lot of work every single day, but I think it's one of the most rewarding things I've ever done in my life. And I think if you're ready to put in the work and you're ready for your manager to, or you're ready to put in the work, and you're ready to, work like you've never before, I think it's a good job to start in. Just if it's something you love. If you don't love it, there's no way you can start out in it.
Okay.
Know that you love it.
What if somebody has applied to the burn unit, but there's no openings, or is interested in the burn unit, but there's no openings? What type of nursing do you feel like would well prepare somebody while they're waiting for a position in the burn unit specifically?
I would say any kind of like trauma nursing or ICU nursing would be really helpful, just because all burns are considered traumas. So you do need to have that trauma background. So I'm kind of learning the trauma, the burn, the ICU, all of that background within my year of working here. Mm-hmm. So it's definitely not easy, but it's worth it.
That's awesome. I love that advice. So what's the process of training on the burn unit as a new grad?
So I went through a 6-month-long orientation / residency program where I went through with other new grads in different units in the ICUs that really wanted to start out in critical care and had a passion for a certain, critical care floor. Mm-hmm. And basically we would be precepted by a preceptor, and they would not only, kind of show us the ropes of the floor, but they would really introduce us into nursing as a whole, since we really hadn't had any experience whatsoever. You know what I mean? And that was, I think, especially special because there were people that really, I think, brought me into the world of nursing. And there's a lot I do now because of those people.
That's amazing. So you had, in your residency program, you had different stints in various ICUs before making your way back to the burn unit. Am I understanding that right?
I'm sorry, no. So I started in the burn unit. We were all placed in different ICUs. So my ICU was the burn ICU.
So you didn't go to various ICUs with your residency program?
Yeah, we maybe had 1 or 2 days in each, just because if we get pulled to another ICU, we have to kind of know what we're doing there. But other than that, it was, basically based off of all one unit.
Gotcha. Okay. Some residencies do a track where you actually get experience in several different critical care areas. And then at the end of your residency, you can apply to the one that suits you most if they're opening. So if some of you are listening and you have that opportunity to investigate a residency of that nature because you're not quite sure what track of ICU you'd like to explore, look for a residency of that nature. Your residency sounds like it really prepared you to the fullest to be the best burn ICU nurse that you can possibly be, which is amazing. And I wish that all our new grads had that opportunity. What do you feel like are the characteristics that make a nurse successful in the burn ICU?
I think motivated is definitely one of the biggest ones. Mm-hmm. Caring and compassionate, because you do have a lot of people that, their whole life has changed from this burn.
Right.
And they don't necessarily know what they're going to do next. So you have to be the one to sit there with them and talk to them, and tell them, like, we're going to get through this together.
Right. And it's interesting when this question gets brought up, because if you really look at it in the whole world of nursing, what you just said is applicable no matter where you're at. But that motivation to be the best nurse that you can be in that specific area, whatever area it is that you choose as a new grad, all of those are still the same. You still need to be motivated to learn something new every day. You still need to be interested in evidence-based research that's coming out and new to your area. All of those characteristics, kind of broad spectrum over nursing as a whole. So Roxanne asked, are there any certifications for your specialty, and how did you prepare for that exam if you've taken it?
So I personally haven't taken the certification exam yet, which is called ABLS, Advanced Burn Life Support. However, as part of my orientation, I did have to take a burn course, where we learned about the different types of burns, the treatments for the burns, and what we do specifically in our burn center, as far as, preventing them, stuff like that.
Okay.
And a lot of the nurses on my unit also have are trauma certified.
Okay.
So I did go through the trauma course, which only certifies me through my hospital.
Okay.
I'm looking into getting the trauma certification, like the ACCN.
That's great. Good for you. And how long would you recommend a nurse practice prior to pursuing certification, whether that be trauma or burn?
I would say probably at least a year.
Okay.
In that specialty.
Great.
You have like that idea, and you're not going into it completely confused. You know what I mean? There's a lot that you're going to have to know when you go into that certification. And working just makes it a little bit easier, I feel like.
You get some of that experience under your belt, some of that terminology is familiar to you versus solely textbook based, right?
Right. Yeah.
Yeah, great advice. So what would you say the best parts of your job are? Several people asked that question.
Yeah, so I love answering this question. That's my favorite part. Good. I think that the best part of my job is getting to see burns, especially the big ones, go home. Walk out of the hospital. It is the most amazing thing. They're with us for quite some time.
Yeah.
So we develop a relationship with them. And I think that's one of my favorite parts too, is that you really get to know your patients. Because even if they're not there for a long period of time, they usually come in and out for different surgeries. You know what I mean? And, they're with us. So they get to know you, and we get to know them. So I just think the best part is, like, especially when it's a huge burn that, is potentially life-threatening, and, the patient comes in intubated, not able to talk, not able to, kind of do anything on their own. And then they walk out of the hospital. It just makes us all cry,
That's amazing.
So I think that's definitely my favorite part, is the recovery.
Yeah, that sounds great. So in your specific unit, do you care for them from ICU intubation all the way through discharge?
We do, yes. So that's
amazing.
Yeah. So not all burn units do that.
Right.
But our burn unit thinks it's, better for continuity of care.
Yeah. So is your unit kind of divided up in the ICU section and the step down section and the, floor status section? How does that work in the dynamic of the unit itself?
Yeah. So we have an ICU section, and then we have a step down section. Okay. And all of our nurses are cross-trained in both. So not necessarily, like, someone who works in the ICU on Monday might work in step down Tuesday.
Okay.
And then back to the ICU on Thursday. Do you know what I mean?
Interesting. So in your training, in your 6 months of training, did they start you in the step down side and then move you to the ICU side? And then when you're off orientation, you're free to travel just like all the other staff nurses do?
So they actually started us in the ICU side.
Oh, interesting.
Yeah. And that's because they wanted us to kind of get firsthand with the dressing changes. A lot of times in the back, which is our step down area, patients go to a separate area for dressing changes. Okay. And it's a little more confusing, and the room's small and you're not really able to kind of talk about what you're doing in the dressing change. Whereas in the ICU, most of them get done in their room. Okay. Can't necessarily leave their room. So it's a lot more space to be able to talk about, okay, this is what I'm doing. I'm applying this medication, stuff like that. So I was really grateful to start off in the ICU to learn more about burns in general. Okay. So
that's interesting. So is it a wound care team that then takes care of those dressing changes when they go to that step down side?
So it's the same people. Okay. Yeah. It's just that
less availability for there to be multiple bodies in there learning.
Right. Yeah. So we have like what's called hydrotherapy rooms. And that's where the patients go that are usually in the back to get their dressings done. Okay. Just because the rooms back there, they want to give them a little bit of difference, especially when they're awake and they're able to understand things. A dressing change is extraordinarily painful. Yeah. And they want to try to give the separation of their room and where they get their dressing change done. I know they do that especially for kids a lot. Mm-hmm. But even adults, there should be a separation. So they'll feel more comfortable going back to their room.
That's great. So what would you say the hardest part of your job is?
I think the hardest part of my job is there's so many different things to learn. There's so many things that are changing every single day. Mm-hmm. And I think that's the hardest part to, try to say like, all right, even if I don't know this, that doesn't mean I'm stupid.
Right.
So I think that's probably the hardest part is really that there is just so much to learn.
For sure.
And I mean, I love that there's so much to learn. I love it so much. It's just also really hard because especially when you're a new grad feeling like, well, I didn't do enough today. You know what I mean? But I had one preceptor that told me I had a patient that like the room was a mess because like the patient was not doing well all day. Patient still had a pulse at the end of the day. The room was still a mess. And I said, I'm really sorry for this mess. Like, I'll clean it up before I go home. Like, I was feeling really bad. And she said, no, you know what? Nursing is a 24-hour job for a reason. Yeah. And the patient had the pulse, so you got through your day. Go home and go to sleep.
Absolutely. Nursing is a 24-hour operation.
Yeah.
As long as you're not leaving stuff on a consistent, habitual basis where it becomes a habit, then we all have to give each other grace. I'm so thankful that you were told that and given that guidance.
Yeah, no, I definitely appreciated it.
Absolutely. And I hope you continue to pass that on to new orientees that are coming down the pipe, because it's so important for us to be able to say, I can leave that for my colleague coming on shift. They can handle that. It's okay, instead of feeling that weight of having to go and do all the things and get all of it done. Like, it's okay to say, here, I left this for you. I apologize I didn't get to it.
Yeah.
So I'm going to be honest with you. My least favorite thing about the burns is the smell. When we would get burn patients into the pediatric ICU, the smell just got to me. How do you handle the smell?
So I hear that a lot about the smell of burn patients.
Yeah.
Just the smell of burns in general. Mm-hmm. The smell of the procedures we do for burns. However, for me, it just never really bothered me. And that was the whole joke, because when I started out in the burn preceptorship, when it never bothered me, they said, well, that means you're a burn nurse. You have to be. Because so many people can't stand the smell.
Yeah.
And we have a lot of people that come in our unit for shadowing and stuff, and they'll pass out the second they hit the room.
Wow.
So, you know what I mean?
Yeah.
It's just, there are so many different ways to deal with the smell. For me, it doesn't really bother me. Some people put like Vaseline under their nose or like vapor rub.
Yeah.
And like put their mask on.
Mm-hmm.
So basically for us, even before COVID, we all had to wear masks and hats and gowns and gloves and shoe covers when in a dressing change, just because of the infection rate with burns.
Yeah.
And that's just because they're missing a lot of skin.
Right.
And skin is our first barrier of defense, which, you know, people may know about from anatomy. And I think that is an important, I think that's important to wear. And the mask, I don't think it helps really get rid of the smell.
Right.
But it's, you know, if you make a face, that's what people have told me, that if you make a face in a mask, it's not, you know, not the end of the world.
Yeah, no, you can see the face that you're making.
Exactly. Yeah.
That's
but personally, it's never really bothered me. I've always really just enjoyed, you know, helping in the dressing changes and stuff. It is a lot to learn, though.
So does your unit take all age ranges from pediatrics through adults, or are you solely adults?
Currently, they do.
They take the whole spectrum.
Yes. Mm-hmm. They take babies through, you know, older adults.
Yeah, that's impressive. Our unit in the pediatric ICU, we would occasionally get the random burn patient. At the hospital I did most of my work at, we didn't have a burn-specific ICU. And so they would typically just go to the trauma ICU. And so our pediatric patients, whether they were a non-accidental trauma or a motorcycle accident, or vehicle accident or whatever it was, they would come to us. And it was really rare, but man, on those occasions, that just really, I wasn't my favorite assignment. I mean, I just really struggled with that. Kevin says, I struggled with the heat of the room and all the gowns and masks and such. It was only 1 or 2 times that I thought I might pass out. I hear that.
Yeah, so that happens a lot. And they do keep it really hot in the burn center. And that's also because of burns. When you have a lot of burns, especially 3rd degree burns, you're losing a lot of heat just because of the lack of skin.
Right.
Yeah.
Do you feel like these are our last nursing questions, and then we're going to get into the more patient specific questions, which I know people are super excited for. So do you feel like the burn unit specifically is a high stress work environment? And if it is, how do you decompress and what kind of support does your unit offer?
Definitely some days it very well can be. I feel like any other nursing job. And I think when I get home, I just take a shower. I, you know, sit in bed. I like to read through Tribe RN, the nursing group. And I just, you know, I try to dissociate from what happened at work. Mm-hmm. And, you know, go either read or, you know, do something that I really like to do.
That's awesome. That's great. So your unit doesn't have any sort of they're called different types of meetings where they kind of decompress. And does your unit offer any sort of formal decompressing as a whole?
So we don't have that, no.
Okay. So we're going to move on to our patient-specific questions. What is your favorite tip or trick of the burn specialty?
What's my favorite trick?
Yeah.
It's going to sound weird, but sometimes there are a few, but I'll give you one in specific. The one tip or trick, it's not necessarily burn specific.
Okay.
But I had a patient that we tried sticking her multiple times and we couldn't get anything, any veins. She did have an IV in, and we really needed blood pretty much immediately. Mm-hmm. So they said, you know what, try to take out of the IV, which doesn't usually happen. And I had a nurse, a more experienced nurse in there with me, and she kind of said, you know, cough. And I didn't realize that helps, you know, the blood come out faster if you have an IV. So just, little things like that
Mhm.
that I think are really helpful. And I think the most helpful tip I've gotten is the one I shared about as long as they have a pulse at the end of the day, that's what matters.
That's awesome. All right. Great tips. So Mary asked, tell us your most memorable wound you've seen in the burn unit and the treatment that was utilized.
Oh, there's so many. We do use a lot of Stantal in the burn center, and basically Stantal is a medication that helps to rip off dead skin in a way. And it is an extremely important medication, especially for the larger burns and the deeper the burn, just because it will help remove dead tissue before the patient goes to surgery.
Interesting.
Have a skin graft. And that's a lot of what I've seen is, a lot of people do need a skin graft, especially if they're, second degree, full thickness, or third degree.
So what's been the most severe burn patient that you've cared for? Not specifically, we want to be HIPAA compliant, of course, but bad car accident, motorcycle accident, head to toe burns. What have you seen that was most, they labeled it, the person who asked the question said most impressive, but I guess we're kind of morbid thinkers. So what's the most impressive burn that you've seen?
I think the biggest burn I've seen is, a head to toe kind of burn. Where not everything is burned, but a lot of things are burned.
Okay.
And, the dressing changes take 2 to 3 hours, sometimes 4.
Wow. And what was the cause of that head to toe burn?
A lot of times they're house fires.
Oh, gosh. That's awful. So Layla asked, what's the treatment regimen that your facility uses most frequently?
So I was talking about it before in another part, but I think Stantal we use a lot. We also use Silvazine, which is an antibacterial. And we use something called Meplex AG, which I'm sure a lot of nurses know. They usually put on skin, ulcers, stuff like that. It does help burn patients as well. And then we do a lot of surgery, just because of the severity of the burn. Even the most Stantal won't help with a third degree burn. You need surgery to heal it. It won't heal on its own.
And with a head to toe burn, what kind of surgical procedure are you doing?
Right. So that's a really good question. So a lot of times with a smaller burn, they get skin from somewhere else, which is called a donor site. And they mesh it. We have this thing called a mesher. And they mesh it into a certain number of, like it's either 1 to 2 or 1 to 4 or 1 to 8. And that kind of blows up the skin a little bit so that you can take a small piece of skin and get a bigger piece of skin. And that's why when you see burn patients like as recovered sometimes, it kind of looks like they have scaly skin. And that's from the mesh graft. A lot of other things we do, if they don't have, available much skin, we do something called ReCell or ACell.
Okay.
And that's pretty new. It's basically spray on skin.
Oh.
So you take a little bit of the patient's skin. It's like very, very little, not less than a donor site. And they make it into skin cells and you spray it on the patient's skin. And we do that for a pretty severe burn. So they usually have to be about 30% to do that.
Wow. I went to college with a former burn patient, and she had multiple grafts. And at the beginning of her injury, she actually had to get a donor graft because she was so severely burned. And her body at one point rejected the donor graft. Is that something that they still do? Is donor grafting, or have they moved to the, I think you called it ACell?
ReCell or ACell.
Okay, so
different names depending on the brand and
okay.
But they do have cadaver skin, and they have used that multiple times before. I I'm not an expert in that at all.
Okay.
I think that it's a really interesting, thing to be able to do is get that cadaver skin and be able to give it to someone else and make it their own. Do you know what I mean?
Have you ever seen a rejection from a cadaver skin?
I personally have not.
Okay.
But I know it does happen.
Yeah, interesting.
And we do a lot of sheet grafts as well,
Okay.
for things like the face and the neck. So basically, a sheet graft means that it's just the piece of skin from somewhere else to, let's say the face. And that's just because your face is like a precious area, whatever, and you don't want to have mesh on your face.
Right.
Whereas your arms or your stomach, it's people are more they're okay with having, mesh if it means they're gonna heal.
Yeah, that makes sense. Becky asked if your facility is using tilapia skin for grafts.
So no, they are not. I have heard about this. It's funny because I actually just heard about it the other day. We were talking about it. We have not started to do that yet.
Can you teach us a little bit about it or the little bit that you do know? What exactly is it?
So I don't really understand it myself, but I do know that tilapia skin is a good, it's different than human skin, but it's similar.
Is it like the fish tilapia?
Yeah, it's the fish tilapia.
Oh, okay. And
that's basically all I know about it, though.
Okay.
We haven't really gone into depth. And I didn't learn, I just read about it in an article. It wasn't,
I'm going to have to look that up because I'm curious to know if they're utilizing it as healing properties in terms of like laying it on the burned skin to promote healing, or if they're actually like in the question, it's kind of implying that they're grafting it to the skin, which would be really interesting.
Right. Yeah. So I don't know. That's a very new, topic. I do wonder a lot about that myself, and I think it would be so interesting to be able to see the patients that have had a good impact from tilapia skin.
Yeah,
it's really amazing what kind of things we can do now.
I know. I love learning new things. It's so interesting. Okay, so Christina asked, what's the best home treatment and dressings for those mild burns at home?
So the biggest thing to know is no ice. Absolutely no ice.
No ice.
Do not put ice on your burn.
Huh, okay.
A lot of people say, ice on your burn is the best way to go. That's inaccurate. It basically will shock the system even further. And basically what happens is it vasoconstricts your blood vessels.
Right.
If you have a burn, your vessels are already vasoconstricted. So it vasoconstricts them even more, and it could lead to something like an amputation.
Oh, wow. Okay. Well, that's really good information.
Yeah. But I think, the best thing you can do for an at-home burn is, especially if you don't have like burn supplies, is to, run like lukewarm water over it, which is, I know a lot of people know that for cooking burns. So run some lukewarm water over it. Don't put any kind of creams on it until you have it checked out.
All right.
So.
Good advice. So Lindsay says, there's a debate amongst my ER nurses here in rural Arizona where we don't deal with burns much. We've had a second degree or higher burn. We are preparing to transfer to a burn center. What do we do for it? One says clean sheet only. One says to place ice water on the burn, and one says silver to the burn. Which would y'all prefer in your institution? Is there any of these part of your own protocol?
So that's a really good question. And I think that every institution is a little bit different. So I don't want to speak for all institutions. I do know that less is better, though, because we are going to have to do a full dressing change when they get there. So if they, spend time wrapping it, the patient's just going to have to go through that twice. And definitely not ice water on a burn. Like I said before, that's something that we just don't do.
Okay.
Because it does shock the system further.
Good advice. Okay. So hopefully that answers her question. So essentially don't do anything to it. Just leave it alone until they can transfer out.
Yeah, I mean, put, a sterile towel, something like that over it, but there's no need to, um, do a full dressing change.
Okay. So I'm just going to say this. I don't know at what point in the healing this child was at, but in my memory, the very worst burn patient I've taken care of, we were putting we had a tub of Aquaphor, and by tub I mean like an entire vat of Aquaphor, and 3 times a day we took his dressings off and lathered. He was grafts. I know for a fact it was grafts, actually. Mm-hmm. He had a donor graft and a recipient, one on each leg. And so we were doing dressing changes on both and literally lathering the Aquaphor on his legs and wrapping them with the gauze, essentially. Is that still common practice?
100%. Yeah. So after you have surgery, after you have a burn graft, it tends to get very dry.
Yeah.
And Aquaphor really helps to moisturize it. Mm-hmm. And we want it to be like not wet, but as wet as possible.
Okay.
And that helps the healing process. So we do use Aquaphor and Nivea, those kind of creams.
Yeah.
But that's mostly after they start healing.
Okay. So that's a post-graft. We're healing nicely. That's not a fresh burn.
Yeah, so we would never use it on an open wound.
Okay, good. So Tara asked what the average length of stay is for a burn patient.
So that's a really good question too, and it really depends on the severity of the burn.
Yeah.
Some people come in with just, a forearm burn, mm-hmm. And it's pretty severe, but they're going to have surgery and then go home in the next few days.
Mm-hmm.
Whereas people that have, accidents and that have, house fires, stuff like that, usually stay at least 2 months.
Wow.
So.
That's a long time, right? But especially in your unit being a full length of stay facility, that's so cool that you get to see them from most critical to out the door. That's so neat.
Yeah, I definitely love that.
Yeah, that's really, really neat. Danielle asked if you see a lot of children.
We do see children once in a while. I wouldn't say a lot of children, but once in a while we do see them.
Okay. And what are you most looking forward to in your career?
Just learning so much more about burns and learning more about education and how I can help educate people. There's not much that I know that I can educate right now, but there is a lot that I'm starting to learn, and I think that it's so important that we educate everyone.
That's great. I know Tara asked, what type of patient education do you provide on your unit? That's just standard protocol type education. And if nobody else has questions, this will be our last question. So get them in if you have them.
Sure. So I think that the best, well, not necessarily the best, but the most education we do provide is on how to treat the burn once you do have it.
Okay.
Just because we are treating patients that already had a burn
mm-hmm.
accident of any kind. So it'd be sort of callous to tell them this is how you prevent the burn you just got.
Sure.
However, we do, work it into our patient education to explain to them how to prevent further burns. You know what I mean? We do a lot of patient education on, grafts and when you can go back to work and what it's going to be like. And we don't do that alone. We do that with PT and OT and social work. So burns is a huge interdisciplinary, area. And I think that basically a lot of people have to work to get something done in burns.
And nutrition plays a huge role in the burn patient's outcomes as well, right?
Yes, and recreational therapy also.
Mm-hmm.
And that's just because, nutrition, you need a lot more protein if you're that sick. So a lot of times we put in feeding tubes in our patients, and recreational therapy, and that's just to keep them, alive.
Right.
Not necessarily alive like pulse alive, but alive like they want to be alive.
Like functionally, right? Like if I've got an arm burn, I need to figure out how I'm still going to put my toothpaste on my toothbrush. And so learning those functional life skills again with this restricted movement is really important, because you want them to have that drive and that ability to do those things independently still. And so I think that functional physical therapy and occupational therapy is so important. How early in their therapy or their treatments, I'm not necessarily saying days, like, oh, on day 2 we do this, because obviously that's not realistic, but more so, do you guys try to get these therapies in line as early as possible?
Absolutely.
Mm-hmm.
We start it as soon as they're admitted, honestly. We always have PT and OT come to the first dressing change,
Awesome.
just to take a look and see what they are going to be able to do,
Right.
What they'll need to do.
Yep. Agreed. Because when it's all dressed, it's hard to see, like, oh, the burn is on the anterior or posterior, because that restricts movements based on where the burn is, full thickness
100%.
here and moderate here, etc. So it definitely matters for physical therapy and occupational therapy and everybody to see exactly what's going on underneath those dressings, right?
Yeah. So that's like a big thing we do during dressing change, is every time after we cut everything down, PT and OT are called into the dressing room to take a look at the burns and see how they healed, see what they can do to help be more functional.
That's great. And actually, I was just thinking about the increased fluid volume that these patients needed, and we didn't touch on it earlier in the discussion. So why don't you just briefly talk about the absolute necessity for these patients that are outpatient at these rural hospitals, how important that piece of it is prior to transport? Like that's a big thing, right?
Right. So that's one thing that the outpatient hospital should do, is we use something called the Parkland formula, and it's based on the percent burn and the weight, and it basically tells you how much fluid they need to get within 24 hours, and it's usually a lot more fluid than you would expect.
Right.
Especially someone with a larger burn. You can be hanging almost a liter of fluid an hour.
Right. So those are things that are really, really important for these outlying facilities who don't care for burns. That that's something that I think is so helpful, and it does get missed. We would receive these burn patients into the PICU, and you could just tell right away that they were just absolutely dehydrated. And so preventing that dehydration from the beginning is really vital in their healing in the beginning stages.
No, I completely agree. It's important, and we do it for all of our, burns that are, significant. If it's, a hand burn, something that is less significant, we won't necessarily fluid resuscitate them.
Sure.
But if it's a pretty significant burn where they've lost a lot of fluid, fluid resuscitation is definitely something we're going to either have the other hospital start, or, we'll start when they come in.
Awesome. Well, that is such great information. Is there anything else that we've missed along our conversation that would be really helpful for nurses who maybe don't take care of burns on the daily, or are interested in burn nursing? Any other tips or tricks or information you'd like to share?
So again, I'm just a new burn nurse, and I don't know that much. So I don't take everything I said, take everything I said with a grain of salt. This is just from my own experience. But I do think that burn nursing is a special place to be. And for those of you looking into it, you definitely should look into it even more. If you have any questions, you can please reach out to me. And for people that, don't see burns on a daily basis, but do come across them, take a look really at, what the burn is. Look at the burn and, just appreciate the fact that, I don't know, just appreciate the fact that you're able to be a part of that care.
Sounds great. Is there any specific is there any specific location that you like to go to for burn education in terms of like your own research? Is there anywhere that we can look to educate ourselves more on burn nursing?
Yeah, 100%. So American Burn Association is a great spot to look for burn information. And it's certified information. It's not like you're looking on some, website that you don't know for sure has correct information.
That's great advice. All right, guys. And that's all for today. I appreciate you. I'm so glad that you came and chatted with us today. And for the record, you're not just a baby nurse. You worked hard to get where you're at today. Embrace that knowledge that you do have. We appreciate you sharing. And for those of you who tuned in, thank you so much. Keep learning. Have a great day.
Thank you so much.
Bye.